Hej och välkomna allihopa till den här öppna föreläsningen med Elisabeth Nielson om Mdma-assisterad psykoterapi för PTSD. Jag heter Filip Bromberg och jag är ordförande i Nätverket för Psykedelisk Vetenskap. Det är vi som ligger bakom den här föreläsningen. Och anledningen till att vi gör det är att vi ser en stor potential i den här forskningen och vill sprida kunskap och öka möjligheterna för liknande forskningsprojekt i Sverige. Om ni vill stötta vårt arbete så får ni jättegärna bli medlemmar i föreningen. Det kostar 300 kronor per år eller 200 kronor för studenter. Och då får man tillgång till våra interna kommunikationskanaler och våra medlemsaktiviteter som till exempel journal clubs, seminarier och medlemspubbar. Det var ungefär det som jag ville säga. Elizabeth, it's a real pleasure to have you back in Sweden. Elizabeth has been a therapist on the trials for psilocybin-assisted psychotherapy for alcohol abuse disorder. She has also been a therapist in the recent MDMA-assisted therapy trials. And she's also the co-founder of Fluence, which is a company dedicated to education and therapist training. So without further ado, warm applause for Elizabeth.
Hi, everyone. Okay. Is that off? Do we want to turn that off? Well, it's really nice to be here, and it's nice to be here again because this is actually my fourth trip to Sweden as a researcher coming to collaborate on programs and events with NPV. So as I introduce myself, I just want to start with a moment of gratitude and thankfulness for the NPV network for bringing me here, for making this talk possible, and not only for this particular talk, but for all of the work that they're doing to bring together psychedelic science researchers and create presentations and create opportunity for the local community to get involved. Lots of people ask towards the end, you know, how can I get involved in this field? And my first thought is that if you're here and you're involved in NPV or you're associated in some way, you are already doing that. You are already a big part of this. So thank you for being here and making this possible. So by way of orientation, it's going to be a little bit of a lengthy orientation statement here, and hopefully by the end of it, you'll have a better sense of who I am and what I'm doing here and what we're going to talk about. But as Philip said, my name is Elizabeth Nielson. I'm a psychologist. I am from New York. And one of the things that I do is work on research as a therapist of MDMA-assisted psychotherapy for post-traumatic stress disorder. And that's going to be the focus of the talk today. And before I get into that content, I'm going to tell you a little bit about some of my other activities that'll give you a little bit more of a thorough picture of who I am and how I got to be doing what I'm doing here in the research that I'm going to present to you. So just to kind of list some of the affiliations and groups that I work with now and how my work is supported. I currently work at NYU School of Medicine in New York at Bellevue Hospital Center, which is a large public hospital, largest public hospital in the United States in New York City. It's famous for its psychiatric treatment programs. And NYU has an affiliation with Bellevue and conducts research there in psilocybin-assisted treatment for alcohol use disorder, amongst other things. I gave a talk here last year that presented some of that research. And I'm a study therapist on that study, as well as a qualitative follow-up study for that particular research project. That work is funded by Hefter Research Institute and River Styx Foundation, and the donors that are affiliated with those groups. And that work is led by the researcher Michael Bogenschutz, who's a psychiatrist at NYU. I also work at the New York State Psychiatric Institute, which is part of Columbia University in New York, on a trial of psilocybin treatment for treatment-resistant depression, which is funded by Compass Pathways, which is a UK-based corporation dedicated to making psilocybin available through medical health care systems to those who need it as a medicine for depression. And that's a large multi-site trial. My role in that is as a therapist, who's actually providing the therapy, as well as training therapists who are going to work on that trial. I also work at a private practice research site conducting research that's sponsored by MAPS, the Multidisciplinary Association for Psychedelic Studies. And MAPS is a nonprofit that's sponsoring multi-site research of MDMA for post-traumatic stress disorder, MDMA-assisted therapy. That's the research that I'm going to be talking about today. So their support for that work makes that work possible. I previously had some grant funding from our National Institutes on Drug Abuse as a young researcher's funding program that allowed me to develop my own program of research, and that program took place through NYU School of Nursing. And again, I just want to say that this talk in particular, and my presence here, was made possible by support from NPV. And I want to give special thanks to my colleague Ingmar Gorman, who's my business partner in Fluence, for his work in helping to prepare this talk, as well as Ilse Jerome from MAPS, who helped with some valuable input and feedback in terms of just making sure that everything that we're saying is as up-to-date and accurate as it can be. So this is a collaborative project. It takes a lot of people and a lot of contributions and help to make something like this happen. And of course, it wouldn't happen without all of you being here to show your interest and attend and hopefully ask some questions towards the end. As well as all of the people that have participated in this research and generously lent their time and attention and willingness and feedback over the years that we've gathered the data that I'm going to be presenting here today. So, without further ado, I'll say one thing about Fluence, because you're going to be seeing the logo on all of these slides. It's an independent company, just two owners, myself and Ingmar Gorman, and we are launching our program to provide education for healthcare providers in psychedelic harm reduction, psychedelic integration in psychotherapy, as well as eventually psychedelic assisted therapy itself when that's available outside of trials. So you can find out more about that at our website, which is fluence8.com. I've got some cards later. If you'd like to take one and look us up, we'd be real happy to hear from you. Okay. So, I feel more comfortable when I know kind of what to expect, right? It's a little intimidating to be in a room and you're like, what are we going to talk about? We talked about all this stuff already. What are we actually going to talk about today? Here are some things I'm going to cover so you'll feel a little more oriented and maybe not quite as scared as this poor kitten. That is not actually a research trial subject right there. That's just a depiction. We're going to talk about what is MDMA. We're going to talk about what is PTSD, post-traumatic stress disorder. We're going to talk about what is MDMA-assisted therapy for PTSD. How does that work? What does it look like? I'm a therapist, so I'm going to give you the therapist's perspective. I'm going to give you a lot less of the neurobiological, pharmacological perspective. That is certainly a great perspective and a valid one, but mine is coming from the therapist side of it. We'll talk about how it might work psychologically and in the long term of helping someone to change. And we'll talk about what the studies show so far and where we might go from here. And then we're going to actually open it up to some audience Q&A. So this talk is really going to be probably about 30-35 minutes from now that we'll be wrapping this up for Q&A. So if you've got questions, I'm going to ask you to hold them, maybe write them down, and then we will come back and find some out. Before I get on to that, though, I want to actually ask you guys one question myself, or actually a couple of questions, a series of questions. Can I just get a show of hands? How many people here, this is their first like live lecture or event in psychedelic research or science? It's like, wow, you guys are awesome. Congratulations. There's so many of you. I'm so excited you're here. Welcome. Really welcome. I hope you enjoy this and I hope you have fun. And, you know, it might be a little like overwhelming or confusing, or if I'm referring to things that you're just not familiar with yet, please keep coming back and ask questions and, you know, send us an email, ask for some notes or some clarification. This is really for you, and I'm thrilled that you're here, and I'm gonna hopefully hope that this won't be your last. So if I do my job, you'll come back for another one. NPV puts on a great series, so that's fantastic. How about anybody here who is a practicing therapist? Like you see patients in some capacity. Okay, great. And is there anybody here who, for who their dream is, I want to be a psychedelic therapist? Okay, all right, great show of hands. Wow. So I might talk you out of that by the end of the evening if you're still convinced. No, I'm kidding. It's a great job, but it's certainly got its challenges. Okay, so let's talk a little bit about MAPS. MAPS is the funder and sponsor of this research. MAPS was founded in 1986 by Rick Doblin. If you're not familiar with him, he was someone who really dedicated his life to figuring out how to make MDMA a medicine after it was banned by our federal government and shortly thereafter worldwide in 1985. So that's Rick up there. You see him speak at all kinds of conferences and on TED Talks and things like that. And he's really been a pioneer in this field. We wouldn't be here without him. But he's got a great team of supporters and other people that collaborate on that work too. So it's not only Rick, but Rick is really our leader in this field. So just to pause for a second, we're going to talk about MDMA-assisted psychotherapy, but the larger concept of drug-assisted therapy or psychedelic-assisted therapy is really something kind of novel in our field of psychiatry and psychotherapy that can take a little bit of like wrapping one's head around, right? And part of the concept of it is that you're actually building on this interaction effect between the intense experience of the psychedelic drug and the container of the psychotherapy and the relationship that's going on around that. So the context in which that is taken. It's not just about the pure pharmacological effects of the psychedelic or about, only the psychotherapeutic relationship, but you're really seeing a mixing and a synergistic interaction effect that we think is really responsible for the results. And sometimes you'll see researchers try to like separate those things out or boil it down to what are just the pure pharmacological effects of psychedelics. And you can look at that. It's interesting. But really when we're talking about psychedelic assisted therapy, we're talking about how do these things combine to create change. Michael Bogenschutz, who I mentioned before, wrote this quote in a paper on drug-assisted therapy that came out in 2013. And I think what's important here is that he's really pointing out that not in psychedelic assisted therapy, we're not just counting on the acute effects of the drug, but we're counting on the longer term changes that the psychedelic experience begins to engender in people. right? So it starts off a process, and we see these enduring changes long after the drug has left the person's body. And that's not something we see with most traditional psychiatric medicines, right? If you think about it, if you take a benzodiazepine for a panic attack, your panic goes away while you're under the effect of the benzodiazepine, but guess what? It wears off, and it does not expected to have some enduring effect on your relationship to panic, right? Doesn't go there. Another thing that that he's pointing out is that these clinically relevant effects seem to be related to the subjective effects of psychedelics, the actual experience of what it's like to be on them during that time. And this is also different from what we expect when we take a more traditional psychiatric drug, right? It's not so much about the experience of taking, what you experience during the acute effects of a benzodiazepine for a panic attack. It's about just sort of quelling those symptoms, right? And this is a difference. This is a shift, and this really represents a sort of a new way of thinking about the use of psychiatric medication, if you want to call psychedelics that, in the context of psychotherapy to affect change. So kind of keep that in mind in the background as we move forward. What is MDMA? There's a lot of, I think it's an interesting drug because there can be a lot of misinformation about MDMA. It's sold in for recreational use under such names as ecstasy, Molly, things like that. And we really distinguish what we're talking about in the research as pure MDMA. It's important to remember that recreational use or any MDMA or something sold as MDMA outside of research is not necessarily pure, does not have controlled origins, does not have controlled dosages, and can vary greatly in terms of potency, quality, and effects, right? So when we talk about MDMA in the research, we're talking about pure research grade, medical grade MDMA that is very expensive and complicated to make and very well controlled. But just for background, MDMA was patented by Merck in 1912. There's some rumor going about that it was patented as an appetite suppressant. That is not true, although it is in the amphetamine class, and amphetamines were sometimes given for weight control. That was not the purpose of MDMA. It was an intermediate drug in the process of manufacturing a blood clotting agent, which did not actually see any pharmacological use in a way that it was fully developed for approval. So this patent basically sat on the shelf and expired until, excuse me, mid-1970s. A chemist named Alexander Shulgin, working in the United States. Alexander Shulgin had been a career chemist who had a special permission from our drug enforcement agencies to continue the development of novel psychoactive compounds in his own lab on his own. And he was sort of well known for developing all kinds of novel drugs and testing them out himself. And in the 1970s, he came across the recipe for MDMA, and he made some, and he tried it out himself, as he did with most of what he made. And he described it as an easily controlled, altered state of consciousness with emotional and sensual overtones and with little hallucinatory effect. Okay. So it's distinguished from the classic psychedelics like LSD and psilocybin because it doesn't have a lot of hallucinatory effect, a lot of visual distortions and distortions of perception, but it does have a sort of distinct altered state of consciousness. Another important thing to point out is that, again, it does have that amphetamine base, so it does have some amphetamine type side effects and can affect the body in a similar way to amphetamines. So over the next 10 years or so, he began to distribute MDMA, create it and distribute it to therapists that he knew because he thought it could be helpful for therapy, and many people agreed. And thousands of sessions were given with in psychotherapeutic settings where therapists were just using this as an adjunct to psychotherapy. And this was not, it was not medical use, so it wasn't an approved medicine, but it was also not regulated, so it wasn't illegal. It was just sort of in a non-regulated research chemical zone. So it wasn't a prescribable medicine. It also wasn't a scheduled illegal drug. And there was no placebo-controlled randomized research conducted because because it was off patent. No one was really pursuing the massive amounts of research that would have needed to be conducted in order to have it approved as a medicine because it wasn't illegal and it could just be distributed and given to patients, right? So it was sought after illicitly as well, and by the mid-1980s, it was gaining more and more popularity and nicknames such as ecstasy, which certainly helped with illicit marketing. It was sought after because it's a stimulant. It elevates mood. It could induce euphoria, feelings of wellness and peace and happiness and calmness and closeness with others and things like this. And it was beginning to become more and more popular in circles of recreational use, with some, potential for danger, for dangerous interactions going on there, especially, outside of the more controlled therapeutic settings, and it began to be more and more popular. And as it began to be more and more popular, that's where law enforcement sort of started getting a hold of, like, what is going on with this drug. People are using this drug. It's not illegal, but it's also not a prescribable medicine. And that's where the authorities began to be concerned about it. Okay, it didn't really come on their radar because of the therapeutic use. It came on their radar because of recreational use. Just to give you a real quick overview of what it does as far as effects on neurotransmitters, it's structurally similar to methamphetamine, so it primarily releases and inhibits the uptake of dopamine and norepinephrine, and it's also primarily serotonergic. It leads to the release of oxytocin and prolactin, which help with sort of feelings of bonding and closeness. And those, although it's hypothesized, we're still like hypothesizing and understanding the neurochemical mechanisms. There can be increased empathy and trust that can be correlated with the amount of oxytocin elevation, and how that all precisely works and how those releases actually translate to the feelings that are coming up under MDMA it's still something that that researchers are figuring out. There's still a lot that we don't understand, and this is a very active area of research. But I just wanted to kind of give you this overview because it's important, and it's not going to be our main focus. Like, we don't quite know how this goes from a chemical compound that you ingest to the actual subjective feelings of it. But the subjective feelings of it are really what's important for the psychotherapy, right? So starting in 1976, as I said, MDMA was being used by psychotherapists. In 1985, the United States Drug Enforcement Agency caught wind of this recreational use and classified MDMA as a Schedule I drug, meaning that it's on a list of drugs that supposedly have no medical value and very high addiction potential. This was, again, in relation to political pressure and recreational use, the medical community at the time suggested that MDMA be placed on Schedule 3, which would have made it a prescribable medicine. But since there was not enough research to actually back up that classification, the DEA came in and said, well, here's what we're going to do based on what we're seeing as far as recreational use. Interestingly, there were 2 court rulings by the DEA's own administrative judges stating that MDMA should not be placed on Schedule 1 because the evidence wasn't there to support it. But that is what happened. And in 1985, Rick Doblin was already at the DEA attempting to stop this process and to protest this process, and then beginning the process of gathering the data to demonstrate that MDMA should be a scheduled prescribable medication, and that process is still ongoing today. So that's the process that we're still in. Right? I kind of already talked about that, so let's talk about post-traumatic stress disorder. Post-traumatic stress disorder, abbreviated PTSD, for those who maybe less have a clinical background, I'm going to kind of go over what some of the basics of the symptom profile look like. Before I do that, I just want to mention that, we're getting into a little bit more of the human story here, and we're talking about things that that really relate to some of the most profound suffering that human beings experience. And we wouldn't be here if we weren't really dedicated to working with people in a compassionate manner and helping to resolve the trauma and the suffering that we're seeing. It can sound a little dry when we sort of, put up some symptoms on slides and present it this way. But I would bet that most everybody in this room has some sort of personal connection to someone who's suffered with something along the lines of related to this, or may have, witnessed something themselves that could sort of help them understand how someone might wind up feeling this sort of way. So I just want to voice that and put it out there that it's normal to have a personal relationship or some kind of response or reaction to this kind of material. And that's part of the constellation of what brings us here and what motivates us here. It's not something that needs to be sort of cut off from your experience or cut out of the conversation. Okay. So when we talk about post-traumatic stress disorder, we're talking about a pretty specific set of symptoms that occur in response to the presence of a traumatic event in someone's life. And that traumatic event can be something that the person themselves either experienced or witnessed or heard about happening to someone very close to them, right? So it could be a violent accident that you didn't witness, but that it happened to a close loved one that you then heard about, and by hearing about it developed PTSD and became traumatized. Okay, that last little bit of it was actually added in the most recent edition of the DSM. So the criterion have sort of been updated and expanded over the years. But what's important about PTSD is that it involves really significant impairment and distress. Not everyone who witnesses or experiences a traumatic event develops PTSD. We don't know exactly why some people do and some people don't, although there are some predisposing factors and some correlations that we can make. It's not a guarantee that certain people will get it and other people won't. So there's a sort of set of symptom clusters that I'll just kind of go over and give you maybe a couple of examples. Arousal and reactivity are symptoms really that it means like physiological arousal, startle response, insomnia, sleep disturbance, things like that. Maybe risky behavior just because of difficulty making an accurate appraisal of how risky things actually are, or what kind of fearfulness is naturally generated by the proposal of doing something risky. Intrusion refers to intrusive thoughts, feelings, or memories, such as, extreme rumination or remembering of the event, people having sort of flashbacks or intense thoughts and memories about the event that are occurring sort of every time they close their eyes or every time they go into a quiet space or something and get distracted. Very intense intrusive thoughts that are difficult to step away from or to let go of. Negative alterations in cognitions and mood. This is an interesting one. People who have PTSD can have a very negative appraisal of the world around them or outlook on the world around them. It can sort of manifest as the sense that the world is a really bad place, the sense that no one is trustworthy, the sense that the individual themselves is a really bad, damaged person. There's something like inherently broken or wrong with them. And these are really very pervasive perceptions that can occur with PTSD. And when working with people, it can be tricky because that's how they're experiencing the world. It's not just like they're able to tell you, oh, I have this weird perception that, I am broken and something is wrong with me. They're actually experiencing that way. So that's one of the things that we have to really assess for very gently and carefully and with very understanding manner. That's where they're coming from. Avoidance of internal states and external triggers means avoiding perhaps things that remind the person of the event or things that remind them of the emotions associated with the event. It can be avoidance of people, avoidance of certain type of work, but it can also be avoidance of certain emotional states. It can be avoidance of experiences of joy and happiness, right? It can be quite a lot of different things that people can avoid, and they sort of construct their whole life around avoiding things that are going to set off the PTSD symptoms. Now, not everybody has all of these symptoms, but when we look at the overall picture of PTSD symptoms and symptom clusters, these are the kinds of things that we see. Okay. And there's some other stuff in the criterion about, these symptoms must have been present for a certain amount of time, and they must have an enduring effect. And I think the most important thing is that they're causing significant impairment and distress in the person's life. Okay. So why MDMA for PTSD? We just talked about some of the things that PTSD is associated with, and these are more of the some of the more neurobiological ways of describing them, but down here you see heightened fear response, right? That hypervigilance, as well as avoidance of behaviors or places and things like that, or avoidance of emotions. So that would be emotional numbing, lack of trust, which is a manifestation, another way of saying that negative outlook, no one else in the world is trustworthy. And MDMA is associated with sort of the opposite set of things, a sense of safety and trust, a reduction in fear and defensiveness, a reduction in an ability to actually go towards and think about traumatic memories as opposed to avoiding them, right? So this is where MDMA becomes potentially a very good fit for working with post-traumatic stress disorder. It kind of creates a window of opportunity in which those symptoms are not so overwhelming that the person can maybe experience what it's like to not be in that state, and then learn from and incorporate that experience into their life going forward. So let's talk about MDMA-assisted psychotherapy. This is a basic outline of what MDMA-assisted therapy looks like in symbols. So bear with me for a second. You've got two things going on here. You've got these little lines that represent non-drug preparatory sessions, and then you've got these big circles that represent actual experimental sessions or MDMA sessions in some cases, placebo sessions if the study includes a placebo condition. But we won't go into that right now. You've got your preparatory sessions, your experimental sessions, and then you've got 3 integration sessions. This is the way the current psychotherapy is structured in the trials. So you see that in between each of these experimental sessions, the participants spending a good amount of time, 3 90-minute sessions with their psychotherapy team, 2 psychotherapists, both preparing for the next upcoming session and integrating the last one. Where it says integration sessions here, I mean, this is a little bit of a shorthand when we say integration sessions in between the experimental sessions, because naturally during these 3 integration sessions, we are working on integrating whatever occurred during this session, but we're also a little bit looking towards preparing for the next session. So, planning for what's it going to be like, what is any anticipatory anxiety coming up about it, and those sorts of things. We've already done the bulk of our preparation around, procedures and things in the very beginning, but we're always kind of looking to the next session in there. And this is intensive, but it's a fairly big commitment. I mean, these experimental sessions take place about 4 weeks apart. So it is a visit almost every week for the course of about 4 months, right? 4 to 5 months. It's a pretty heavy time commitment, pretty intensive form of psychotherapy. Most people who are used to going to psychotherapy are going to 1 session every week, maybe even every other week, and that's often just a 45 or 50-minute session. So this is quite a lot. It's quite an intensive amount of time, and it takes place with 2 psychotherapists, not just 1. All of the sessions are conducted by a co-therapy team in a controlled setting, supportive environment. Our psychotherapy session rooms. Sometimes the psychotherapy is conducted in the same room as the session. Usually that's the case unless there's a scheduling issue. We have to be in a different room. But it's a supportive environment, looks a little bit more like a living room, hopefully less like a hospital or an uncomfortable medical treatment room. And during this session, you'll see this is just one way of setting up a room. There are some variations, but this is actually Michael and Annie Mithofer who developed this therapy, this way of working with someone who is pretending to be a participant for the purpose of the photos, and they are set up on either side of the participant. You can see, it's hard to see, but they've actually got a blood pressure monitor. It's pretty much the only medical equipment that we would have visible in a room like this, but the rest of the room has artwork and flowers and is made to look like a very comfortable home environment, right? And the therapists are there to help the person prepare. There's focus on the memories and emotions that may come up during the session, that are coming up during the session, and they're really there to help the person focus on their internal experience, as opposed to focusing on any sort of directed psychotherapy or particular leading the participant in a particular direction. One way to describe this therapy is that it's inner-directed, and it's really about having the person develop their own sense of their intuition about what's going on with them, as opposed to the therapist imparting a particular way of understanding the problem. This is a great article. I'll let you guys check it out. It's in the MAPS bulletin, which is free online on the MAPS website, maps.org. You can look it up. If you just go to that website and put in something like this title, you'll get it. Michael Mithofer wrote this a few years ago, and it talks about MDMA-assisted psychotherapy, how it's different from other kinds of therapies. But I'll give you a bit of an overview. These are some of the elements that he described, and it really incorporates elements from various different methods and approaches, right? So there are psychodynamic elements. We think about and we talk about transference and countertransference. We talk about the multiplicity of the psyche, the sort of sense that there are maybe different competing versions of self or aspects of self that might get better aligned with each other through this process. We talk about somatic manifestations of trauma. A lot of people with PTSD have a lot of like somatic complaints or somatic symptoms that can be seen as related to the stress and the trauma. There are elements of exposure therapy in that people may be able to sort of walk themselves through talking about the traumatic event in a way that's helpful, but it's not exposure therapy in that we are directing people through a specific narrative about what happened to them under the influence of MDMA. So I want to kind of make that clear distinction. And some other things going on. So it's an interesting mix. And then I think that for each co-therapy pair each co-therapy pair has different backgrounds and different orientations to understanding trauma, and some of those things can work their way in as well, depending on what the therapists in the room are trained in and are experienced with. So let's talk a little bit about preparation sessions. There are 3 of them. We start with things like building rapport, eliciting some history. We talk about safety a lot. Excuse me. Everyone in studies is very well screened for any potential risks or safety concerns that we may have, but we definitely talk to people about preventing falls and how we will provide assistance to them should they want to stand up or move about or go to the bathroom and those things. And we're trained to assist people as much as is needed. We talk about touch, and this is something that most psychotherapists in training are really basically taught. You never touch your patients, and don't ever do that, no matter what. It's just sort of off the board, and then it's not really talked about, even like what might the ethics around touch be, should that be something that you're going to engage in with your patients. But therapists that are conducting these research trials and that have completed the MDMA therapy training do receive special training in the ethical use of touch and how to use touch in a way that can be ethical and helpful and comforting for participants, if that's something that the participant is helpful with and wants. It's always optional, but we can use touch always in a safe, non-sexual way to perhaps help participants modulate emotional experiences or express emotional experiences, or just to provide reassurance and grounding during intense experiences. And that can be a very powerful and effective way of connecting with someone and seeing them through a session. Again, there's more on that in, I believe, in that article that Michael Mithofer wrote. And if you're interested in further discussion about it, there's another great article in the MAPS Bulletin that is an actual document of the ethical commitments of MDMA therapists, and that includes some language on that and explains a little bit more about our approach to it. So I would direct you to that as well. We're trained in the use of language that is inviting as opposed to commanding, in ways of phrasing things that are designed to more elicit more about the participants' internal experience as opposed to presupposing what we think they're experiencing. So there's a lot of that goes on, and it creates a very supportive atmosphere. We'll also, in preparation, assess and provide self-regulation tools. So we might, practice some breathing methods, or talk to the participant about ways that they regulate difficult emotional situations outside of the study, and what they might do to help themselves should they wind up feeling overwhelmed. And that goes for both during the session and after it. Okay. So what about these dosing sessions? Sometimes we call them overnight sessions, experimental sessions, dosing sessions. What do? People come in the morning and we start on time, and that's very important because it's a long day and we don't want to be there late into the night. But the general setup for it is that there are 3 of them. Each one is optional after having completed the last one. So if somebody ever says, well, I did one and I don't want to do any more, then study participation is always completely voluntary. People sometimes do say that, and of course we honor that. But the idea is, the program is that people will actually get 3 of these sessions, and that's kind of nice because then there's not a lot of pressure in the first one to really get through everything. People can kind of learn a little bit what that state is like and how to use it. So we ask people to maybe form an intention, but then let go of an agenda about exactly what they want to experience. We talk to them about, focusing on their internal experience. During the first 90 minutes of MDMA, there can be some anxiety and some arousal as the amphetamine-like effects are beginning to take hold. And so we do work with people to kind of, practice a little bit of calming practices, or maybe put on some more calming music. But after 90 minutes, we'll really be encouraging people to go into that anxiety, explore that anxiety, stay with and follow through with any difficulty that may come up. But again, it's an invitation to do that, an invitation to go inward and explore, as opposed to a command or a push. Right, and it's done in a very supportive atmosphere. Right. Integration sessions. These guys outlined here now in the red circles. Again, this is where we're really getting into more of a psychotherapy with the participant. The bulk of it tends to come out in these sessions, I think. We're constantly assessing for safety, any changes in symptoms, any sickness, any problems that are coming up, and that's just part of being part of the study. We keep in touch with our participants after the sessions. We're very available to them. We're on call. We're very available for phone calls. There's a lot of follow-up that happens. And we know, and we remind participants, that sometimes people feel more stirred up after the experimental sessions. And sort of the things have been stirred up, memories have been stirred up, and that it can take a while for that to sort of naturally unfold and settle down, and for the changes to become apparent. And we're really there for them as we're sort of seeing them through that process, right? So it's important for the therapist to be comfortable with that process in order to give the participants space to go through that process, and let things settle on their own, right? Another thing I think is important is that, when there's positive change, or even great insights about the nature of what's been going on with someone's PTSD, or maybe they are feeling remarkably better, it can still take time to adjust the life that they had built in order to manage having PTSD symptoms, right? So there can be adjustment in relationships, adjustment in just people's repertoire of behaviors and the things that they're used to doing. For instance, if someone has really been avoidant of social interaction because of not wanting to stir up their PTSD symptoms, and then they become more comfortable with social interaction, they may suddenly find themselves like, wait a minute, I now I'm going to need to actually start calling people and going out and making friends. Like, this is going to take a while to really get a social life off the ground, right? So those kinds of changes don't happen overnight. That can take some putting into place, and therapists are really there to support participants and see them through that process. Right? Make sense? Good? You with me? Okay. talk a little bit about mechanisms of action. So in the psychological domain, psychedelics we tend to talk about the mystical or mystical type experience, and psilocybin is sort of the famous psychedelic for occasioning mystical experiences, psilocybin and MDMA. We don't see that as much with MDMA, although we see a little bit of it, but it doesn't have that same type of mystical experience profile. What we see more of, I think, with MDMA is a sort of interpersonal and intrapsychic domains that people make discoveries in, or make some new understanding in, and it can be a very sort of autobiographical experience as opposed to more of a classic mystical experience. So just kidding. I want to actually skip to, hang on a second, one thing, therapeutic alliance. Okay. How do we understand some of the underlying mechanisms of action? MDMA can promote, we know from animal models, fear extinction. It can allow for memory reconsolidation, so remembering things in a way that they then become remembered differently in the future, and MDMA does converge on some of the same pathways as other psychedelics that we're finding helpful for change, like LSD and psilocybin, important for neuroplasticity, especially BDNF, as well as creating structural and functional neuroplasticity. One finding that I think is really interesting is that in mice, MDMA makes adult mice brains look a little bit more like adolescent mice brains, with a greater reward for being social. So social activity being more rewarding. And if you think about how that might affect a psychotherapy session, you are, for people with PTSD, psychotherapy could be really hard because you're expected to, relate to another person. And if that feels very painful, it can be hard just to even be there. But MDMA can make it a lot easier to experience that relationship and a lot more rewarding, right? And that's one of the things that we're seeing actually in animal models. Does MDMA reduce anxiety, acting like a benzodiazepine or other anxiolytics? Well, this is a good question. The effects have been really hard to quantify, but let's take a look at some actual data on that. This research led by Matthew Baggett came out a couple of years ago, and I like it because he's comparing MDMA to placebo and showing what profiles, what people endorsed more of or less of. So for instance, we can see that it makes people, here's really like the time peak of MDMA right around 2 hours at like sort of most intensity, between 90 minutes and 2 hours. So yes, more enthusiastic, more kind, more loving, but also more anxious than placebo, right? People endorsed more anxiety. People endorsed less of feeling relaxed, more of feeling stimulated. Okay, this kind of gives you a little bit of a quantification of the effects. I think this is probably the most interesting for our purposes of all of these. MDMA decreases social anxiety. So very specific anxiety about being in relationship with other people, right? Probably helpful for psychotherapy. And it increases authenticity. So the feeling of really being true to oneself and truly able to express oneself and being able to be authentic and honest in the room with the other people during this experience. And again, I think these are sort of the things that we are asking of people when they come into psychotherapy in order to benefit from that. And MDMA may be one of the ways that it works is by helping that relationship be more possible and helping people actually connect with their therapist and experience that psychotherapeutic relationship. Kind of move along here to some of the phase 2 results. This is caps for reduction in total severity after 2 to 3 MDMA sessions. This is from phase 2 data, pooled data that was published a couple of years ago. And just so you kind of get a sense here, this line, the black line, actually represents just about the place where, sorry, this pointer is a little bit drunk. It's hard to aim. This black line is about where the caps is the measure of PTSD severity going along here. It's indicating about where people move from having like where you would say they qualify for having PTSD to not, right? So up here is like, yep, this is above the line is like, yeah, you've got, enough symptoms for a PTSD diagnosis, and this is sort of below threshold. And as with any measure, clinical judgment comes into play, but that's sort of a rough estimate. So these are the drops in scores after stage 1. This is one session with a dose of either 75 or 125 milligrams. And this is one session with a comparator dose of either 0 or 40 milligrams. So that was used as, the 40 milligrams was used early on as a low dose to find out if it worked or if it would be considered a placebo. But you didn't see the same stage in CAP scores. This was these same people moving from that blue circle over here and having an open label follow-up where they got MDMA. They were told they were given MDMA, and it was either 100 or 125 milligrams. That's 27 people. And then this is actually 12-month follow-up with everybody from here and here all together, and you can't quite see it, but there's a blue circle behind the yellow square. So everyone having actually dropped, both groups having dropped below that score, right? These are the ranges. You can see the ends of the ranges of people's scores. So some people got really low. Some people were actually still above the threshold, but you do see that the average was generally very far below that mark. So this is pretty remarkable, and I want to point out that this is with 1 to 2 doses of MDMA, right? And these are enduring results at 12 months. It's a small group. It's a pilot study group. It's not a conclusive, this proves something trial. But this is the kind of evidence that we're seeing that's, leading to the phase 3 trials that we're doing now. At the conclusion of treatment, another way of looking at the same data, 100 participants, 77 of which had 3 sessions, and I think the rest of which only had 2. Conclusion of that 12-week treatment, 56% no longer met criteria for PTSD, and at 12 months, 6 of 90 of those people who participated in 12-month follow-up, 68% no longer meeting criteria for PTSD. Now, we don't know what happened to the other 10 that did not participate in that follow-up. They may have had a resurgence of their symptoms or not. It's not included here, but they did. The people that did participate showed a continued and sustained lack of PTSD symptoms. Okay, So let's talk about long-term follow-up. That long-term follow-up was actually a year, but the range was from 17 to 74 months. So the average was actually 45.4 months. It's quite a long-term follow-up. This is a smaller follow-up group, and 19 of those people participated. 19 completed the questionnaire, and this is the long-term follow-up for that group. Baseline caps. This is when they came into the study. This is where they exited. Where they exited the study, and this is that 45-month follow-up where you see continued sustained reductions. Right? PTSD symptoms significantly improved after 2 MDMA sessions in active dose groups. Again, we've got our primary endpoint. What I think is interesting here is that this is demonstrating 3 different groups with 30 milligram, 75 and 125 milligram dosages, and the 30 milligrams you didn't see a significant difference, but both of the 125 and the 75 milligram group dropped, and you actually saw more of a drop in the 75 milligram group than in the 125 milligram group. So again, small groups, small scale results, but very significant and promising beginnings. Let's take a look at depression symptoms improved. Significantly improving after 2 MDMA sessions in the full dose group. So again, the 30 milligram group not showing that much change, but both the 125 and 75 milligram group showing it. And this is a full dose MDMA for stage 1. This is again 12-month follow-up. So we basically took that one. I'm looking for another one specifically for you. Okay, this is the one I'm going to kind of wrap up with. Post-traumatic growth after MDMA-assisted psychotherapy. People who experience MDMA-assisted psychotherapy may also not just see a reduction in symptoms, but actually see something that we call post-traumatic growth, or I guess you could kind of describe it as a personal growth, feeling sort of taking their experience into account and then beginning to actually build on it and feel maybe better as a result of having been through the entire process, or having incorporated the entire process into their life. And there's a paper that is actually just in publication right now. It's going to be up in just a few weeks, and I will share with you, because I'll share it with you through the network. Ingmar Gorman, my colleague, is actually the first author on this paper, so he's lent us this graph to check out in the meantime. And what he's showing here is that people who had an active dose of MDMA actually showed growth, personal growth, psychological growth at the primary endpoint for their PTSD treatment. So that is this right here. At the secondary endpoint, they were over here, and the combined groups. This is this group, then moving up here with the secondary endpoint, and then the combined groups are showing an actual sustained post-traumatic growth, both at treatment exit and through endpoint. And I think this is interesting because we're kind of looking at two sides of the coin here, right? We're looking at a treatment for a problem that can lead to perhaps symptom reduction and the alleviation of the problem. But the people that go through this process are actually showing gains in other areas and gains in other ways that can actually be quite positive in terms of their long-term trajectory of development in their long-term life. So perhaps getting something even more out of the treatment than just, okay, my symptoms are gone now, right? And I'm alleviated from that. I encourage you to check out that paper. One more thing I'll point out is there aren't a lot of other studies going on with MDMA at this point, but one small study that has already concluded was Mdma-Assisted Psychotherapy for PTSD in couples. Anne Wagner came and spoke about this, and both at the conference that NPV put on, and I think at a separate talk here. And that's a video that's definitely worth checking out if you're interested. But it's a great study to be familiar with, where they actually gave MDMA to both people in the couple at the same time, and had a psychotherapy session with them. And the idea was to treat one partner's PTSD in the context of the couple relationship. So definitely worth checking out. So I'm going to wrap up here, and we're going to move on to some questions. I want to put up some info for you about contact if you're interested in actually joining a trial, or you know someone who is. I don't believe they've started recruiting in Europe yet, but they will soon. The website is mapsptsd.org. You can also find other trials at clinicaltrials.gov. That's a US website that lists all trials internationally. You could find me at elizabeth@fluence8.com, as well as on the web at fluence8.com. Please look me up. I've got some cards. And before you guys are out of here, we're going to do some questions and answers. Sound okay? Thank you. Thanks.
Thank you so much, Elizabeth.
Thank you.
So I will be running around with a microphone. It would be great with another person. Maybe Mike, could you help me out? It's just because there's 2 stairs and so on.
2 stairs.
I want to start by asking you a question while I get the other microphone out.
Okay.
If you could say something about implementation. So we're hearing that it's likely to become approved in, what is Rick saying now, 2022?
Whatever Rick says is definitely true.
So what is, in the best of worlds, how will this happen?
So Rick often shares an estimate of when MDMA will potentially be approved for medical use if that's what happens, which we're all very hopeful about. But it's a long process, and estimates are estimates, and they have, I caution you that they have been revised already during this process, just because it's hard to predict exactly how long things will take. I believe the current estimate is 2023, and that is for approval for use in the US as a medicine in some capacity. But you also have to keep in mind that in order for use to occur, each team that's using MDMA for psychotherapy or providing MDMA-assisted psychotherapy will need special education, special licensure, special approvals and permits and things like that. So it doesn't just mean that, like, the law is going to change overnight and just like the ATM started spitting out euros, it's going to be like MDMA coming out everywhere, right? It's going to be a process once that happens. So, yeah.
Hi. Could you talk a little bit about this non-directive approach during the actual experimental sessions? What kind of questions do you pose to the patient? And also, could you say something about neurotoxicity? Do you do any assessment of that?
Mm-hmm. So, well, I'll go first to the non-directive approach. So when we say non-directive approach, it's actually, the term we're using more often is inner-directed approach, and we're asking people to sort of turn towards their internal experience with an attitude of curiosity and openness and explore what they find there. Explore their own psyche, their own memories, their own emotions, their body sensations, their feelings. When we say non-directive, what we're talking about is we're not trying to direct them towards any particular process or towards any particular solution that we've already figured out, and we're just trying to like lead them to it, right? So another way of saying it is we sometimes use the phrase, we don't want to get ahead of the medicine or ahead of the participant's process. We really want to allow them to go be their own leader and be their own explorer. And we're there to support them and talk about what they come up with. Make sense? Okay. And that's different from the way a lot of psychotherapies are, where the therapist kind of has an idea like, okay, this is what's happening here. And they may be asking specific questions to help the person sort of get to that conclusion themselves. But they've got that preconceived idea of how it works. As far as neurotoxicity, actually one of the slides that I skipped was about the R bands and just demonstrating that we're not seeing cognitive functioning decline in any of the doses that we're giving in research. I know that there have been people who have expressed concerns about neurotoxicity related to recreational use in recreational settings, but the doses that we're using in research of pure research grade chemicals are not, and in the frequencies and amounts that we're using them, we don't have concerns about neurotoxicity for that used in this way, in this regulated way. And everyone is also very carefully screened for any pre-existing condition that could potentially interfere with taking MDMA.
I wanted to ask, how did you hear?
Oh, there.
How did you choose the 3 sessions would suffice? Also, do some people metabolize MDMA at a faster rate than others? So do you then administer a higher dose? And do you sometimes continue administering more than 3 sessions if the PTSD has not subsided?
So the way that the research is constructed, we have to have a pretty specific research protocol of how many sessions we're doing for each, and everybody kind of has to have the same dose of therapy. And so that means that there's not flexibility at this point in the research studies as far as how many sessions are available to people. And the number 3 sessions, it sort of came a little bit out of some trying things out during earlier phase 2 sessions. What's good about it is it gives the participants a chance to have more than one session, so they're able to get kind of familiar with what to expect and get over the anxiety of the first session, and then have a little bit more time to work things through in a second and third session. And as far as dosing, there is some flexibility as far as if the dose of the first session is well tolerated, there's a chance to raise it for the second and third session. And there's also the use of a supplemental dose so that kind of extends the window of the time period during which people are under the effects of MDMA. Right? So there's a little bit of flexibility built in there. Yeah, and again, post approval, there may be room for more flexibility to sort of tailor that treatment, and as far as number of sessions, and frequency and those sorts of things. And we don't have that right now.
Hey, I guess I had kind of a similar question. So I was kind of wanting to ask about physical effects, and then if a patient could moderate their own treatment. So it's kind of similar, but I was thinking maybe for some it might be like too intense for their condition. So maybe they could like regulate their sessions and be like, my team, could I maybe like ask for a later session? But you said that there's a flexibility, so I guess kind of answered my question.
Yeah.
Okay.
Yeah. There's not a lot right now. Of a lot of flexibility right now, but even though we're following a research protocol, we're also guided by our best clinical judgment. So if we were working with somebody and we deemed or decided in perhaps in in conversation with them that the therapy was too intense for them or this frequency of sessions was too fast for them, then we simply wouldn't, work with them in the study. We would, want to have them be a candidate for, potentially post-approval use or treatment or something like that. So we're really careful to try to select people that are also going to be able to kind of go through this process. And if it's not clinically relevant, or if we feel at any point that someone would be better served by returning to a different treatment or no longer taking this particular treatment, then we won't continue it.
Right. Thanks.
So people aren't locked into it. Yeah.
And then is there any case of addiction?
That's not something that we're seeing in after use of MDMA in studies, and it's actually a great question. It's not something that we're seeing after use of psychedelics in psychotherapy studies in general. These experiences tend to be pretty profoundly intense and not so distant from the ideas of what it would be like to use this recreationally that it doesn't show up like that. Yeah.
Thanks.
Okay. Definitely very interesting and hopeful results. But there is a shadow around this substance, MDMA ecstasy, at least in Sweden, like 10, 15 years ago. There were very strong warnings against ecstasy, saying that it was actually very toxic to serotonin neurons and creating chemical chronic depression after use. So, of course, the fears is that is this true? Could it be caused by like these doses, or could this treatment lead to stimulation to recreational use of MDMA ecstasy after treatment?
As I've said, that's not in line with what we're seeing in research trials. We're not seeing, this turn into addiction, recreational use, or any kind of neurotoxic health consequences. So the situation that you're referring to, apples and oranges, perhaps, and I would, look at the sources of where that's coming from, because the actual research with clinical research grade MDMA is not aligned with that.
Hi, sorry that I'm so late. Apologize to everybody. Is it okay if I ask two questions?
Sure.
The first one I was thinking about, maybe you said that before I just came in, but I was thinking about the complex PTSD. I know that this is for PTSD, but do you know that if there are any studies or relevance with this kind of therapy for complex PTSD? Or because I was thinking that maybe if you go into complex PTSD and there are other stuff that aren't solved, that it might cause, I don't know, responses in that person.
So we often see people in the studies that have multiple traumas, multiple sources of PTSD, and that's okay. That doesn't, we're able to treat that just the same. And the other interesting factor about this is that the studies include people with PTSD from all different sources. So it includes people with war trauma, people who have, been exposed to traumatic incidents through their line of work, maybe as a firefighter, emergency technician. It includes sexual assault, victims of sexual assault. It includes people who have been exposed to natural disasters, all kinds of different, domestic violence, all kinds of different sources, and quite often multiple or more than one trauma.
Okay. Yeah. Because I know this type of therapy has been around for a while, right? Before the whole research started, right? Yeah. I was thinking about addiction because there are different theories around addiction that you can, like, once you have been addicted to something, you have to stay totally abstinent. And some people feel that addiction is helped by medical dosing, and it hasn't been a popular view, but it's being legalized in the States, in New York, for example, with the whole cannabis thing. And, you know, is that something you see for this kind of therapy?
I mean, I'm not quite following. Are you referring to using MDMA?
People that already are addicted to some substance. Do you know if this kind of therapy will have any relevance in reducing their? Oh, okay. I can tell you that there is a study going on, and I neglected to mention it, but I should have. It's a sidetrack question, I know, but
yeah, that's not quite what I thought you were asking, but now I think I understand. There's a study going on, recently concluded actually in London by Dr. Ben Sessa about using MDMA in the treatment of alcohol use disorder. Again, it's a very small pilot study, but it's been done, it's feasible. And I think that we may see more and more research using this therapy for treatment of addiction, especially where trauma is present. And we do see a high degree of overlap in the patient populations, people who have PTSD or some symptoms of trauma and an addiction problem of some kind. So I think that there's great potential to use this in populations, especially with that particular overlap. It's not considered a counterindication. These studies aren't studying it right now, but I wouldn't consider it a counterindication or a rule out for the future.
Yeah, but do we see it like solving addiction as a disease, or like if you see it as a disease, do we
potentially
in the future?
I mean,
maybe
it's not. I think it's the therapy itself is has a lot of different potential applications. Right now, other psychedelics are being used a little bit more in research for potential treatment of addiction, but people are starting to explore that with MDMA, and I don't see it as unthinkable at all that it could certainly have that application at some point when the development of that research has been done. Yeah.
Thank you.
Sure.
Hello.
How are you? Hi.
Yes. I'm wondering about the age limits in the group. Usually there's a limit of 50 or 55 years old. And I wonder if there's a specific, this is the same for working with MDMA.
This study actually does not have those age limits.
Oh, that's interesting.
Yep.
In my mind, I understood that it's less taxing on the body with MDMA than a lot of the other psychedelics, but I don't know if this is just what I made up myself. Then you also, because also there is this, I have heard that many people recommend in non-research settings to have supplements for serotonin or stuff like that. What's the approach to supplements, and what's the approach to physical fitness?
Not something that's being included at this point. No.
Okay. And do you take tests to see how it affects people physically to take these three doses? You haven't noticed that there's a lack of some kind of drop in euphoria or something like that?
Not in the research that I'm working on. It may have been done somewhere, but if it hasn't been brought up in a way that it's something that's a concern. I wasn't the one that wrote all of the medical procedures and protocols for this. obviously. But I know that anything that could have been considered a concern, that research would have indicated would have been a concern, would have been taken into account. And that's not something that's a concern, or enough of a concern that it's something that we're monitoring. People are monitored, very closely for psychological problems and extreme distress and emotional stability and things like that. But at this stage of testing, the physiological safety of MDMA is well enough established, I would say, that that's what we're focusing on. Right? In order to get to phase 3, you have to have a certain level of established physical safety of the drug, and that's kind of where we're at.
Thank you.
Right.
Hello.
Hey.
I wonder, what do you think about persons that are already on antidepressive medication, and if it's possible to combine, or if you recommend not to, and what is maybe the problems if you combine?
So again, I would just say research isn't at the point of testing combined therapies and combined medications and those sorts of things. But I'm going to give a somewhat more general answer than you're probably hoping for, which is that in research, everything has to be very much separated out, and we wouldn't include things that could potentially be a confound and then would disallow us to be able to tell from what we got our results. Right? So we're being very specific about people being in, who are in the research in this treatment and only this treatment at this time, right? So that we can tell if the results are coming from this particular treatment. Make sense?
So you don't know anything about risks?
That's not what we're researching right now, and it's sort of beyond. It would be beyond the scope of this particular research, because right now we're measuring this drug administration and only, so that we can tell what the effects of it are in a cleaner manner than if we have, people taking this therapy and various other things, and it'll be very hard to tell what we're actually seeing, what we're actually looking at, right? Makes sense? And I apologize, because it would be great to have a much clearer rundown of all of the different potential combinations and potential risks, but we're still way, way earlier than that. But maybe that's a study you want to do. Get started. Yeah.
All right. Hi.
Hi.
I'm here. Yeah, thank you so much for the work you're doing. This is great news, I think. I work in psychiatry as a clinician. And I'm curious about non-responders.
Mm-hmm.
If you have non-responders in the studies, or people who deteriorate with treatment, and if you can say something about what ideas you have about why there would be a non-response if that happens.
Mm-hmm. So the studies that I work in all have a placebo condition, and I don't know. I wouldn't know who has the placebo and who doesn't. What I can say is that it's been demonstrated across the phase 2 data that people who get the therapy only, on average, like the average of the therapy only group, is that they do actually have an improvement in their PTSD scores. It's not as significant as the people who got the MDMA condition, but we are seeing an overall trend towards improvement in that group, just from going through the process, meeting with the therapists, and being there. Now, every average has its outliers, and is it possible that some people could, not fare as well during the study as they did before they came in? Yes. But you also have to remember that PTSD is a very varied and can be a very severe and debilitating condition. And so there's a base rate for people doing worse anyway. But what we're seeing is actual improvement, even in people who aren't getting MDMA, they're just getting the therapy. Small, but there.
So you haven't seen patterns of people not responding to the active treatment? Or
I couldn't really speak to that. It's too soon to say, like, within the active group, if there's a certain subset of people that just don't respond, far too early for that.
Okay, thank you.
Yeah.
Do you know if there are any side effects?
Where are you? Oh, there you are. Sorry.
I'm just thinking there must be some side effects. Are there any known side effects? And also, I'm wondering how the results compare with other PTSD treatments, like, for example, EMDR.
Mm-hmm. So side effects are part of what the study is gathering and collecting. So when we ask people a lot about what they're experiencing, and we're actively gathering that data. So when you have an approved drug, that it gives you a list of what side effects are possible, and this is the study that gathers that data, right? So stay tuned for that. And what they'll do is then compare the side effects that people who took the placebo reported to the side effects that people who actually got MDMA reported, to see what side effects are actually attributable to MDMA, right? And you had a second question? Oh. Yeah. So I think that's a great thing to think about, because not everybody will be a candidate for MDMA therapy, even MDMA-assisted therapy, even when if it's approved. There will be some people who, for physical reasons, can't take it, or for whom they're not a good fit for it. And there are other psychotherapies, EMDR being one. I'm not sure quite how it compares to EMDR statistically, because again, we don't have the results to be able to say exactly what our improvement rates are. We're still gathering that. But I think that alternatives and combined non-drug psychotherapies are going to be very important. What I will say is that exposure therapy is often recommended for post-traumatic stress disorder, but exposure therapy can be something that people find very difficult to do and may not be willing to do. And so even though it can be helpful, and it is an evidence-based procedure, all right, and it is reliably helpful for PTSD, although not for everyone, treatments also have to be acceptable to people in order for them to go and do them, right? So this adds another potential treatment to the pool that people may find perhaps more acceptable than some of the other options. And the same goes with the drug therapies that are out there. There are some medications that are commonly prescribed for PTSD, but there are people that don't want to be on a medication they have to take every day, right? So one of the great things about this is I think it's really going to open up more the field for more patient choice, right? Okay.
Okay, I think we are becoming a little bit tired and hungry, so we're going to wrap things up. If you still have questions, Elizabeth will be here for a little while. If you have questions about Nätverket för Psykedelisk Vetenskap, I will be outside. So thank you again so much for coming, and thank you, Elizabeth.